Welcome everybody to Grand Rounds for April of 2023. Today we have two presenters presenting on the low back pain in dancers, and also the second part is on craniofacial pain. Our two presenters are current residents in orthopedics at orthopedic physical therapy at St. Luke's University Health Network. The first is Dr. Kelly Angelucci. She received her Bachelor's of Science in Sport and Exercise Physiology and a Bachelor of Art in Dance, followed by a Doctor of Physical Therapy at DeSales University. She's currently completing her residency training at St. Luke's University Health Network's Orthopedic Physical Therapy residency. Dr. Angelucci is extremely passionate about dance, specifically providing injury and burnout prevention and wellness support to pre-professional and professional dancers. As a dancer and performing artist herself, she has witnessed colleagues, friends, and teachers giving up on their careers as performing artists due to seemingly preventable injuries. Dr. Angelucci seeks to make resources on injury prevention, treatment, and recovery available to all performing artists. Our second presenter today is Dr. Mabry Brintzenhoff. She earned a Bachelor of Health Science, followed by a Doctor of Physical Therapy from the University of the Sciences in Philadelphia. She is currently completing residency training at St. Luke's University Health Network's Orthopedic Physical Therapy residency. And Dr. Brintzenhoff has developed a special interest in craniofacial pain and developed an expertise in diagnosing and managing patients with craniofacial pain. So please make sure that you remember to sign in to EADS. The information is in the chat box. Please make sure that at the end of this presentation, you complete the quiz and the course evaluation in order to get CME credit or CE credit, depending on your profession. If you're watching the recorded version, make sure you do those as well. If you're doing the live version and you're seeing this today, make sure that you sign into EADS before tomorrow, because the code expires as seen on the screen. If you have any questions, please reach out to me and I'd be happy to answer them. This is the continuing medical education credit information for this presentation. And this is our designation statement. And the planners and presenters have no financial relationships to disclose. So without further ado, I will turn it over to Dr. Angelucci.
Thank you, Dr. Karahoff, for that introduction. Thank you, everyone, for being here. As Steve said, my name is Kelly Angelucci. I will be discussing physical therapy management of the dancer with low back pain. So you might be wondering, why low back pain and why dancers? I chose this topic due to the multitude of dancers I treat and the variability in outcomes when treating low back pain in dancers. Most dancers respond really well to the treatment I have provided, but some demonstrate little to no progress. So I wanted to delve into the literature and find what was present in regards to treatment interventions. Unfortunately, what I found was that there is very little evidence and a poor understanding of the best interventions to address low back pain in the performing artist population. Therefore, the aim of this presentation is to give an overview of the prevalence and causes of low back pain in dancers, explain the typical presentation and how to assess the dancer with low back pain, review what the literature does report as the most effective physical therapy interventions, and discuss a case study regarding a dancer with low back pain. Hopefully, after today, you will feel a little more confident treating this population, or at least know the right things to ask and look for. Low back pain is the leading cause of disability and lost work time in the general population. The U.S. spends about $90 million every year on treating low back pain. Studies suggest that 70 to 85% of individuals will experience low back pain at some point in their lives, and 90% of these individuals will have more than one episode. Low back pain can be classified as acute, lasting for less than 3 months, or chronic, lasting for longer than 3 months. 80% of acute low back pain will resolve without medical intervention in 6 to 8 weeks. Low back pain may not be an isolated issue, but characterized by periods of exacerbation and remission of symptoms, making it challenging to treat without recurrence. Recurrence rates can be as high as 66 to 84% within a year, leaving patients frustrated if this possibility was not addressed by clinicians in previous treatments. Dance requires a multitude of skills not always present in other sports, including flexibility, muscular and cardiovascular endurance, muscular strength, balance, proprioception and motor control, kinesthetic awareness, power, unnatural positions, rapid changes in directions, jumps, turns, foot posture control, and body awareness. In addition to these physical characteristics, dancers also often endure long training days or weeks, depending on the level of expertise, and are highly focused on perfectionism, all while maintaining an aspect of aesthetic ability. Due to the high physical and mental demands of the sport, dancers often suffer from stress, anxiety, depression, self-critique, female athlete triad, disordered eating, or eating disorders, which can all severely affect their performance endurance and physical, mental, and emotional capacity. All of these factors lead dancers incredibly susceptible to injuries, with studies showing a one-time lifetime injury rate of 94% and a re-injury rate between 14 and 44%, specifically in pre-professional dancers. Surprisingly, dancers are often skeptical of the medical system and rarely seek medical care, as dance is a unique specialty and they are often told to simply stop dancing in order to allow for their injuries to heal. This may be an option for the recreational dancer. However, it is not an option for the competitive, college major, or professional dancer. Because of this fear, dancers often push through pain, and studies have shown that dancers develop high pain thresholds in order to keep up with the demands of their sport. Jeffries et al. Found that dancers endure higher training loads compared to other athletes, resulting in higher injury and illness incidences and risks. These dancers, despite their injuries, missed very few performances and continued to train, some with modifications. As you can imagine, this can result in chronic loading and stress on injured tissue that might heal much faster had they been directed to proper care. Due to the repetitive nature of the activity, high training volumes, minimal rest breaks, and lack of a true off-season, dancers suffer more from overuse injuries compared to acute injuries, though this can vary based on the style of dance. While injuries of the lower extremity are most common in female dancers and spinal injuries are more common in male dancers, low back pain was demonstrated to be 12% of all dance injuries and is a very common report due to the extreme repeated spinal extension, high velocity twisting, and unnatural positions of the spine under high load during dance demands. Low back pain in dancers has been shown to have an 89% annual rate and a 60% monthly rate based on current studies. Low back pain affects all dancers alike. However, studies show that professional and pre-professional dancers have a higher prevalence of back injuries compared to amateur or recreational dancers, and is higher than observed in the non-athletic and athletic population. The high rates and prevalence of low back pain poses a concern, as adolescents who suffer with low back pain have been associated to have poorer mental and physical quality of life and adopt care-seeking behaviors, medication use, and activity modification. Not to mention that it can affect their performance quality and overall physical and mental health. Based on your examination, your differential diagnosis should include these diagnoses, but are not limited to, and these are in order of prevalence of what I have seen in the clinic. So muscle strain is most common. According to Renata-Poli et al., 40% of mechanical back pain is discogenic in nature. QL and paraspinal tightness, lumbar radiculopathy, SIJ dysfunction, which can be presented as back, buttock, hip, and leg pain referral, instability, spondylosis, spondylolisthesis, stress fracture, lumbar facet sprain, and pelvic floor dysfunction. Also realize these may not be in isolation. Regional interdependence holds true for dancers. Everything is connected and working synergistically. It is not uncommon for dancers to have more than one of these diagnoses at one time. Here are some other important considerations you might want to ask your dancers on initial eval in order to gain better insight into their current regimen and predisposition for any other injuries. There are a lot of words on this slide. I'm not going to read all of them, but I want you to use this slide as a reference in the future if you would need it. I would like to highlight a few of these. So how many hours a day and hours a week are you training? Again, being aware of their training load and the realization that taking a break from dance right this moment might not be an option. Do you have one side that is more flexible than the other or one side that is stronger than the other? Most dancers will tell you immediately what their flexible side is. This can lead you to muscular imbalances or weaknesses that may align with your examination, which can ultimately lead to SIJ dysfunction. Do you ever have lower leg pain or tailbone pain? Again, teasing out SIJ. Any bowel or bladder changes since your onset of pain? Or do you have any pain when going to the bathroom or using a tampon? The first question can obviously be indicative of cauda equina, depending on how they answer the question, and could also be indicative of a pelvic floor dysfunction. Do you do any stretching, strengthening, or cross-training outside of dance class? Again, can clue you into weaknesses and if they are filling in the gaps of their dance training with additional strength training. While more serious spinal pathology is uncommon in this population, we still need to be aware of it. I have on this slide the red flags associated with metastatic cancer, infection, and vertebral fracture. Also be aware of the possible of abdominal aortic aneurysm, cauda equina, or other inflammatory conditions, and make sure you ask questions targeting these pathologies. If you do suspect these pathologies, you should refer them to an oncologist, physician, or orthopedic surgeon depending on your suspicions. There can be some pretty obvious yellow flags when dealing with this population, especially any self-harm or bodily changes, physically and mentally, that would warrant referral to psychiatry. Disordered eating or eating disorders should be referred to both psychiatry and a dietitian. Most dancers will not want to take time off from dance in order to nurse their injury. Build a picture for them. In the grand scheme of things, 2 weeks or 2 months is not the end of your career. That time off could prime you for an even longer career with less injuries. If any of these yellow flags are present in your evaluations or later down the line, they need to be addressed. While the prevalence of low back pain in dancers is multifactorial, there are confirmed risk factors for low back pain injury, though 90% of cases are nonspecific. These can be some things to look out for or talk about with your dance patients. Decreased hip external rotation range of motion and strength. If a dancer does not have adequate hip external rotation range of motion or strength, especially if they are training in ballet, they will frequently compensate with lumbar spine extension, tibial external rotation, ankle pronation, or all of the above. Any compensation for poor turnout is going to result in injury. Beighton score. Studies have shown that both a high Beighton score and a low Beighton score can place the dancer at further risk for injuries. Poor technique and alignment. This can lead to compensation, as I mentioned. History of previous injury is the #1 risk factor for getting injured again, so don't be afraid to give this education to your dancer. Poor lumbopelvic stability. Any kind of instability, whether structural or due to muscle weakness, can result in pain and compensation elsewhere. Increased sacral inclinations. Studies have shown that increased sacral inclinations are present when the dancer is in turnout or hip external rotation compared to parallel, a position that dancers spend a lot of time in. Hyperlordosis. This can be structural, functional, or as a result of poor core endurance, again, for obvious alignment reasons. Decreased trunk muscle endurance. Both Glidier et al. And Swain et al. Found associations between low back pain and the size and endurance of trunk musculature. Cigarette smoking, specifically in females, were found to place the dancer at increased risk for injuries. Stress. Waring et al. Observed a strong correlation between stress and injuries. And training load. It has been shown that 6 hours of activity a day or 30 hours a week increases risk for injury and the likelihood of developing low back pain. In regards to disordered eating, sex, and overall health, Kane et al. Found all of these factors were associated with the length of time a dancer was forced to modify an activity due to injury. Feel free to use this slide as a template for your examination of dancers. As with any low back pain patient, you should be doing a lower quarter screen if warranted, lumbar range of motion, repeated motions, functional screening, hip range of motion and strength, etc. A lower quarter screen is a quick screening tool used on evaluation to quickly rule in or rule out mobility, sensation, and neurological deficits that might be present. A repeated motions exam is when you use movements, usually of the lumbar spine, to rule in or rule out lumbar spine involvement. For example, if a patient has radicular pain into their left glute area, the therapist would ask the patient to perform a certain number of lumbar flexion in standing in order to create a change, either centralization when the pain moves proximally, or peripheralization when the pain moves distally. This can be repeated as many times as needed to make a distinct change and can be done standing, sitting, prone, or supine, depending on how much force is needed to make that change. Painful lumbar extension can be indicative of paraspinal involvement, lumbar facet sprain, spondylosis, or stress fracture. I would also challenge you to look at your dancer's standing posture from all angles, both normal and their first position turnout. As shown in the picture here, this dancer is in second position turnout. The incorrect picture on the right side of the screen is depicting poor lumbopelvic alignment, resulting in knee valgus and foot overpronation. Most dancers stand in a hyperlordotic position. Genu recurvatum is also a common presentation, which can lead to poor foot control, usually pronated, and poor core engagement and ability to find neutral pelvis, ultimately leading to decreased trunk motor control and proprioception. Though a neutral spine is not necessarily functional, most dancers cannot find this and have a skewed sense of what neutral is. Thoracic mobility is often limited because they have excessive lumbar mobility, again, leading to a functional instability of the lumbar spine. Squat, balance, forward lunge, and step downs are all functional tasks you can use to assess your dancer's overall mobility and control. SIJ dysfunction is also very common in dancers due to high mobility in the area as well as one-sided training. If you feel comfortable, you can also ask your dancer to show you some of these dance-related positions. Scallerud et al. Showed that dancers have the most back pain with these positions: retire, developpe, first arabesque, and cambre, all pictured here. If you do not assess them visually, at least ask your dancers if they notice an increase in pain when performing these tasks during their training. Additionally, as mentioned before, assess their first position and second position parallel and turnout for any compensations, as well as assess the releve, better known to us as heel raises. Overwhelmingly, after doing a literature search, multiple studies demonstrated the need for trunk and core muscle endurance, and that motor control of the pelvis and lumbar spine is significantly decreased in dancers who have low back pain. Improvement in core activation in numerous studies demonstrated improvements in strength, function, pain, and nerve irritation. Poor core engagement has also been shown to position the pelvis in an anteriorly tilted or posteriorly tilted position, which decreases effective shock absorption in the spine and does not allow for proper activation of glute max and hip external rotators. Scallerud et al. Suggested supine bridge exercises to improve core musculature performance in patients with increased lumbar lordosis. Studies have also shown that dancers with low back pain have higher rates of paraspinal fatigability and impaired proprioception. Additionally, loss of pelvic motion may therefore alter the biomechanics of dance movements and may be associated with pain and dysfunction. That is what I found in the literature. I would like to give you some of my go-to exercises for dancers with low back pain. I have found benefit from challenging balance in dance-specific postures, as well as exploring terminal knee extension, thoracic spine mobility, hamstring stretching, and modalities involving cupping and instrument-assisted soft tissue massage. Repeated motions can be very useful for dancers with derangements. I have found that most dancers have weak hip external rotators, which could lead to them forcing their turnout structurally. Additionally, most dancers have genu recurvatum, as I mentioned, and have much difficulty using their extra available knee extension range of motion effectively. Often the cue from dance teachers is, don't straighten your knee all the way, or bend your knee slightly, disengaging the supporting musculature. Instead, I like to give the cue to pull up at the quad and the hamstring, but don't lock your knee. Oftentimes they can achieve this, but struggle with carryover into functional dance activities. However, I have found that terminal knee extension to be a great exercise to address this. Instead of static stretching of the hamstring, I like to do a contract relax of the hamstring at their end ranges in order to engage at the weakest point in their range of motion. Often paraspinals and quadratus lumborum are tight and would benefit from instrument-assisted soft tissue massage. Pelvic floor treatment is something I think is lacking in our toolbox. However, we need to ask the right questions in order to determine if there might be pelvic floor involvement. Treatment could be as simple as adding Kegels during all exercises, or they may benefit from a referral. Lastly, balance is something I feel is overlooked in dance treatments. We assume dancers have good balance, but most times dynamic balance is challenging or the dancer will compensate in static balance. Above all, dancers benefit from in-depth education on injury prevention and physical wellness. Educate them on proper warm-ups, cool-downs, static versus dynamic stretching, diet, sleep, etc. That was all the information from the literature review. I would now like to take the time to discuss a case study of a dancer I treated with low back pain. This dancer was a 16-year-old female presenting with low back pain for a long time, as she said, that she reported had gotten worse over the past couple of months. This patient is a competition dancer and also goes to school as a dance major at the Charter Arts High School, reportedly dancing 30+ hours a week. Her concerns were being able to return to dance with manageable pain. Her pain was midline and reported no radicular symptoms, described as tight, 9 at worst, 1 at best. She only had pain with extension and felt her back was weak. Alleviating factors include sitting hunched, Advil, and heat. She saw a chiropractor fairly consistently for TENS, cupping, and manipulations. Patient denies increased pain at night. Additionally, she sustained a right ankle injury a little less than 2 weeks prior to starting PT for her back, and as a result was experiencing pain in her right knee all the way up to her mid-back. At the time of evaluation, she did not have any pain in her right ankle, but noted instability. Patient's goals for therapy were to be able to dance without limitation, strengthen full body, and have less pain in general. The chart on the right shows some significant findings on examination. This evaluation was performed earlier on in my career, and looking back on this now, I would have also assessed SIJ, multifidus activation, and repeated movements that could have allowed us to reach this patient's goals faster. Lumbar mobility was full in all directions, pain only with extension. Upon segmental mobility testing, L1 to L5 spinous processes were hypermobile, but pain-free. Bilateral lumbar paraspinals and quadratus lumborum were tight and tender to palpation. Glute, hamstring, and hip internal rotation manual muscle tests were 4- or 4 out of 5. All other hip MMTs 4+ out of 5. Her gait demonstrated pronation bilaterally, slight left calcaneal whip, slight left hip internal rotation, and slight right hip external rotation. At the time, I diagnosed this patient with functional instability. However, reading over this case now, I would argue she could have been diagnosed with a lumbar facet dysfunction as well, as I did not perform any tests to confirm or deny functional instability, such as an active straight leg raise or the prone instability test. Had I done this and received positive test results, I would have focused more heavily on core and pelvic floor activation for more effective and targeted treatment. In regards to treatment interventions and home exercise program, I performed the following. Again, looking back, I would not have given her all these exercises on her first day, as none of this really told me what exactly changed her pain, and perhaps would have matched her diagnosis better and ended up with a quicker trajectory of treatment. I saw this patient for 7 sessions, including initial eval, over the course of 9 weeks. Per ortho recommendation, we did ankle strengthening and stabilization and EPAT at her first treatment session for her ankle. Interventions consisted of glute, QL, and paraspinal soft tissue massage, cupping of the bilateral QLs and paraspinals, both statically and during cat-cow and physio ball roll, which is shown here on the slide, piriformis stretch, hamstring stretch, quad stretch, transversus abdominis static activation and with marches, bridge with band, as shown here on the slide, lumbar P to A grade 3 and 4, bird dogs, dead bugs, standing hip 4-way and hip external rotation, which is on my next slide, and neutral pelvis training and squats. So this is the hip 4-way with hip external rotation. So they're standing in their turnout position in order to strengthen that. At treatment session 4, patient reported improved low back pain, but increased thoracic pain, which was alleviated with prone thoracic grade 5, open books, standing spinal extensions, standing rows, and standing shoulder extensions. At treatment session 5, we progressed to dance-specific strengthening with hip flexor march, standing balance in passe with a dynamic hip external rotation, internal rotation component, as shown on the slide, bridge on the ball with a batma, which is a kick, also shown on the slide, and eccentric activation of the hamstrings, both in external rotation and parallel. At treatment session 6, her discharge visit, she reported developing some symptoms characteristic of hip impingement, in which I performed tensor fasciolatus soft tissue massage, inferior hip mobilizations with a belt, and quadruped rockbacks. This patient met all of her goals set on initial eval, including having no pain at her discharge visit. I have a close relationship with this dancer and have been in contact with her since her back injury. 3 months after discharge, she still does not have any pain in her back and does not feel functionally limited by her back injury. She is dancing full out for all rehearsals and classes. Hopefully now you have some more tools in your arsenal to allow you to feel more confident when assessing the dancer. If you don't, you can always reach out to myself or another provider of the Performing Arts Medicine Institute at St. Luke's. We have already received numerous referrals through this program and hope to reach all aspects of medicine in order to treat this population to our fullest capabilities. Some things to keep in mind for our conclusions. Low back pain is rare in isolation, especially for dancers. Make sure you assess the whole dancer. Dancers will push through pain. Give them education they need for autonomy and injury prevention. Don't pull your dancers from activity if you don't have to. Modifications are always available. As with any patient, be aware of red or yellow flags that may arise during your treatments with dancers. And lastly, don't be afraid to educate on what you know best. Warming up, cooling down, good nutrition, sleep, and being consistent with home exercise program and cross training. You will be surprised what they don't know. These are my references. Thank you very much for your attention. I am now open for questions. Feel free to unmute or type in the chat.
Question.
Sure.
So you mentioned in hindsight you would have tested a few other things and perhaps even use a different diagnostic label. Do you feel that would have changed her the patient's trajectory in care? I think you only used it only took like 7 visits.
Mm-hmm.
Do you think that would have actually sped it up any further than that?
I think my treatment would have been more targeted to what her actual impairments were. I don't know that it would have sped up the treatment at all. She was just based on dance schedule, she would have to take a week off here and there. So I think maybe giving her those tools that she could have used at home as well, not maybe doing less manual work in our sessions, maybe she would have had a quicker trajectory. Thank you. We'll move on now. If anybody thinks of questions, you can always type them in the chat box and we'll be open at the end of Dr. Brintzenhoff's presentation, but we will now move on to her presentation.
Thank you, Kelly. My name is Dr. Mabry Brintzenhoff. As Steve mentioned, I'm in the orthopedic residency here at St. Luke's. My presentation today is on craniofacial pain. These are the learning objectives today. The goal is to be able to describe and come up with possible etiologies and differential diagnosis for craniofacial pain, as well as treatments and interventions to help manage craniofacial pain. So there are many possible diagnoses for causes of craniofacial pain. A very common diagnosis is temporomandibular dysfunction, or TMD. 75% of the population have at least one symptom of TMD in their lifetime, with TMD occurring most frequently in the 5th decade of life. It is also more prevalent in females than males. TMD has primarily been treated by dentists and oral surgeons. People with craniofacial pain and TMD often see other physicians like ENTs, optometrists, neurologists, chiropractors, and family practitioners. Research shows evidence to support a multimodal approach to treating TMD and craniofacial pain. And the multimodal approach includes manual therapies, isometric exercise, guided opening and closing of the temporomandibular joint, posture correction, and an emphasis on education for behavior change. Research also encourages a thorough cervical spine evaluation and treatment for people with TMD. Though dentists and oral surgeons are able to efficiently and effectively treat TMD and craniofacial pain, physical therapists are more skilled and equipped to provide this multimodal approach. However, TMD and craniofacial pain are not frequently treated by physical therapists due to not having the knowledge or in-depth training for managing TMD and other causes of craniofacial pain. Here's a list of differential diagnoses for craniofacial pain on the slide, but it's not limited to just these diagnoses. Other differential diagnoses can be trauma or dislocation, sinusitis, and glossopharyngeal neuralgia. TMD can also occur with autoimmune diseases like systemic lupus erythematosus and rheumatoid arthritis. The etiology of temporomandibular dysfunction includes macrotraumas and microtraumas. The macrotraumas include whiplash and a direct trauma to the jaw. Microtraumas include repetitive chewing, bruxism, which is clenching and grinding of the teeth, mobility deficits, and posture. Included a picture of the anatomy of the temporomandibular joint and muscles of mastication involved. Another differential diagnosis for craniofacial pain is trigeminal neuralgia. However, the trigeminal neuralgia, which has multiple etiologies. However, the focus today is trigeminal cervical nucleus convergence. The trigeminal cervical nucleus is located at the bottom of the pons to the right, or to the upper segments of the cervical spine, which I included pictured in the slide. The axons in the trigeminocervical nucleus are closely related and connected to the spinal ganglia of the C1 to C3 spinal nerves. This is what is known as trigeminocervical nucleus convergence. Also, posterior to the trigeminal cervical nucleus are somatosensory afferent fibers from facial, glossopharyngeal, and vagus nerves. This concept can complicate differential diagnosis since pain can be referred from both C1 to C3 and the trigeminal nerve to the forehead, orbit, cheek, TMJ, and ear. Also, pain can be referred to the cervical spine from the TMJ. Trigeminal cervical nucleus convergence can be caused by a dysfunction at the atlanto-occipital joint. I've included a picture of the referral distributions of C1 to C3 and the trigeminal nerve. This slide is a side-by-side view to compare the differences in signs and symptoms of TMD and trigeminal neuralgia. They have many similarities, but one big differentiating factor is pain location, type of pain, and frequency. Pain experienced with trigeminal neuralgia is described as sharp, severe, or jabbing. This pain is usually paroxysmal in nature and unilateral. However, pain experienced with trigeminal neuralgia can become more constant and dull in nature. Another differentiating factor between these two diagnoses is that there will not be clicking or popping in the temporomandibular joint or any joint restrictions at the TMJ with trigeminal neuralgia. It is also not common for people to have tinnitus with trigeminal neuralgia. It's a brief case description of a patient I've recently treated in the past for craniofacial pain. She's a 52-year-old female with a past medical history of Meniere's disease and TMD. Specific location of her symptoms when arriving to physical therapy included jaw pain, pain behind the right eye, tingling around the right side of her mouth and above right eyebrow, tinnitus in her left ear, and fullness in both ears. She also reported an abnormal sensation on her tongue. She associated her jaw pain with grinding her teeth at night and clenching her teeth with increased stress. In the past year of the onset of symptoms, she did have an increase in work and life stressors that had been managed with attending a yoga and meditation class once a week. Her job involved prolonged sitting at a desk with 3 different computer monitors. At the time of beginning physical therapy, she had not yet found anything that relieved her symptoms. She had previously been seen by a neurologist, ENT, optometrist, primary care physician, and chiropractor. For TMD and craniofacial pain, based on research, examination should include posture assessment and TMJ range of motion. When observing TMJ depression, take note of any deviation or deflection that occurs. Also, as mentioned earlier, research supports examination of the cervical spine in addition to the TMJ. Palpation should include the cervical spine musculature and muscles of mastication. I also mentioned the lateral bite test, which is helpful in determining if the TMD symptoms are myogenic or arthrogenic in nature. The dental screen includes checking their teeth for specific tooth pain and visual inspection of the tongue to look for scalloping that can help indicate clenching or grinding of the teeth. The next 2 slides include the examination that I did for this patient and what I had looked at. I assessed posture, mobility, motor control, muscle force and strength, and palpation. After completing the examination, the primary impairments identified were posture, OA mobility, C2 to C3 mobility, TMJ depression, and tenderness with palpation. In addition to these primary impairments, she had impaired motor control of the craniocervical flexors and the right masseter. I also included an assessment of middle and lower trapezius strength later on in treatment for helping prevention of recurring symptoms. The next couple slides are charts of treatments and interventions that I did with this patient based off reassessment of the primary impairments of palpation, OA, and C2 to C3 mobility, and TMJ depression each visit. I also considered her symptoms while choosing treatments. To address these impairments, manual therapy was the focus of treatment, including soft tissue mobilization, OA distraction, high velocity, low amplitude thrust, and a muscle energy technique for improving C2 to C3 mobility. This was then followed up with neuromuscular re-education and soft tissue mobilization for her home exercise program. In addition to listing the treatments in these slides, I listed what she was given for her home exercise program. When adding new exercises to her program, it was always in addition to what her home program consisted of in prior weeks. She was also educated on posture correction, ergonomic setup at work, and changing position at work every couple hours. I ended up seeing this patient for a total of 6 visits over the course of 9 weeks. As symptoms, mobility, and motor control improved, I started initiating exercises to prevent reoccurrence of symptoms like deep neck flexor endurance and middle and lower trapezius neuromuscular re-education for emphasis on posture. On visit 6, no specific intervention or treatment was performed, and it was spent doing a reevaluation, reviewing her home program, providing education on her home program, and education on returning to physical therapy in the future if she were to have recurrent symptoms that she is unable to manage with the home exercises. So with physical therapy in the 6 visits that I saw her, she had overall great outcomes with improving mobility, motor control, and posture. She ended up having normal OA and C2 to C3 mobility and no deflection with TMJ depression at the end of physical therapy. At discharge, there was an improvement in her photo score to 87, and she reported a global rating of change between 95 to 100%. She was comfortable in continuing to maintain and manage symptoms on her own with the home exercise program. In addition to these outcomes, she had an overall reduction in all of her facial symptoms and ear symptoms. To summarize this presentation, there are many differential diagnoses to consider when a patient presents with craniofacial pain. 2 diagnoses that are difficult to differentiate are TMD and trigeminal neuralgia due to the concept of trigeminocervical nucleus convergence and referral patterns. Research and evidence supports management and treatment of craniofacial pain using a multimodal approach that physical therapists are skilled in. Examination should include examination of the TMJ, cervical spine, and posture, as well as psychosocial factors and behaviors that may be contributing to symptoms. Once completing a thorough examination, management and treatment should be focused on the impairments found. Research supports evidence for soft tissue mobilization, joint mobilizations, motor control, posture correction, and most importantly, biofeedback and behavior change. Without changing behaviors like bruxism, posture, and psychosocial factors like stress, it is unlikely that there will be a resolution of symptoms. Overall, with appropriate treatment and management, patients with craniofacial pain have great outcomes when attending physical therapy. So I've provided a list of resources that I found on a blog on the APTA website for additional trainings or certifications to further develop your knowledge in treating craniofacial pain if you're interested. So I hope after today that you have a better understanding of where to begin with examination and treatment of people with craniofacial pain. And now if you have any questions for myself or Kelly, you may ask them or put them in the chat box.
Thank you very much for that presentation. I just have one question about the cervicogenic relationship. And this may be a chicken or egg conversation. But in your experience, do you feel that the cervicogenic impairments and problems are the genesis of the TEM craniofacial problems, or vice versa, that the craniofacial problems started first and then resulted in cervical impairments?
I think in general, it's hard to differentiate that for this patient specifically. I think because of her history of TMD, that was first, and then she started to develop symptoms like cervical and the craniocervical dysfunction that then contributed to the facial pain that she was having. But I agree that it's chicken or the egg, that it's hard to differentiate which started first.
Oh, thank you. Anybody else have any other questions? All right, well, thank you very much for everybody who attended in person and live online, and thank you to those of you who are watching this at a later date. We will be back next month for another grand rounds.